Hi, it's Naresh the orthodontist here, and today I'm going to introduce my retention pathway. This is an information video for my patients nearing the end of their active orthodontic treatment and are about to begin the important next stage of retention. Retention appliances and their supervision is critical to holding on to the result you have worked so hard to achieve. What the research shows. Essentially not a lot, but that's not from a lack of trying. The findings and updates from a Cochrane database systematic review, which reviews the best evidence available, has shown that there is low to very low certainty and they cannot draw firm conclusions about one approach to retention over another. One of the reasons why this is such a difficult topic to research is that even the endpoint of treatment is not the same for all patients. For example, I spend time detailing cases, focusing on small movements and corrections. Others don't always see the benefit of this. Some of us undertake a period of stabilisation while still in active braces, while others, again, don't see the benefit of this. But from the best available evidence, along with an audited review of my own cases, I have found the following points and approaches. Privately treated cases afford the orthodontist the time to treat to a high level of detail, and as a UK trained orthodontist, I have spent, in addition to my 5 years training as a dentist, a further 9 years of dedicated competitive entry training posts throughout the UK to qualify as an NHS consultant orthodontist. But it doesn't stop there. I continue to meet my peers and follow a pathway of lifelong learning, challenging and reviewing new developments as they arise, with the goal of finding ways to critically review and improve my patients' smiles. Often spending months after a case looks like it's almost finished, to improving and tailoring tooth positions further to where patients are more than just liking their teeth, but loving their smiles. There are no shortcuts in life, and few if any cases are treated within 6 months. Most cases require over 2 years of treatment to maximise outcomes while essentially protecting teeth and associated structures from long-term damage. Once you are in your best natural tooth position, I maintain the patient in their active braces to gain some stability before considering debonding. Long term, I use retainers to try and maintain tooth positions, accepting that some natural settling will occur. In time, the face, the bones, the muscles are all changing as part of natural aging processes, and with these changes, the pressure on teeth is also subtly changing. Over the last 25 years of experience, I have found to treat each patient as individuals, but for the majority of cases I have found that the following generalisations do indeed apply. Wherever possible, fit bonded retainers in the lower arch from the canine to the canine and all the incisors in the upper arch. Bonded retainers are fitted at the debond appointment, and here we also take a recorded scan of the full dental arch. After a week, we fit removable retainers to maintain the whole arch. I ask my patients to wear their removable retainers for 2 weeks, day and night, moving to eat and clean. Following this, I ask them to wear their retainers evenings and nights for 6 months, and then only at night for 6 months. After a year, I ask them to reduce the wear of their removable retainers to a few nights a week. This regime is not set in stone, but rather with regular reviews and in-surgery clinical assessments, advice can be tailored. In the long term, I suggest that at least an annual review with your orthodontist to check both the bonded and also the removable retainers. Some maintenance and replacement will be required for both retainers. Currently, from my experience and review of my cases and the understanding of the science, this is generally the system that I have found gives my patients the best outcomes. I hope you found this short explanation of retention informative and reassuring. Thank you.